Hi guys, happy Tuesday. All right, it's about 4:30 in the afternoon. If anybody wants a margarita, just wave your hand and I'll bring it around. Okay, now, I want to talk about something called bundle branch block. Sometimes abbreviated in most textbooks, BBB, like Bravo, Bravo, Bravo. But it'll say RBBB for right bundle branch block and LBBB for left bundle branch block. Now, it's isn't complicated. It's the best drawing I could do today. Every time a ventricle contracts, you get a QRS. Play like these are QRSs. Here's one. Notice I wrote another one. Okay, so there's two. But usually the ventricles don't contract like that. They contract what? Simultaneously together. So we only get one QRS, not two. But let's just say that you had a bundle branch block, right? Okay. So what I'm going to do is make the bundle branch block right here. Okay. Right here where you see the little circle. So watch what's going to happen. This is the first QRS. This is the second QRS. Notice we got two mountain peaks. Now these are commonly called, the first one is R, like Romeo, R. The second QRS is called R with a little dash, prime. And what that means is this. R is the first ventricle, okay, that's going to contract, that's not blocked. But then the electrical impulse is going to come down and hit this block. So what's it going to do? It's going to creep around the block in tissue that isn't really fast conducting and come back and then conduct. So you get two QRSs, one superimposed over the other. R is the first ventricle that fires. R prime is the ventricle with the block. Sorry, the bundle branch with the block, because we're talking about bundle branches. So you can get rid of all the stuff in the middle and just go like a big M, okay? This first QRS represents the bundle branch that is not blocked. The second QRS, R prime, represents the bundle branch that is. And when it comes down R prime, it creeps around this area block and goes back, okay? So this goes just like it normally would, but then this is delayed and it goes second. R ventricle goes first, no block. R prime has a block in it, okay? Now, go a little bit further here. Okay, I want you to grab your books, guys. Oh, wait. Grab your books. I want you to take a look at page 198 in your book. Okay. And you're going to see strip 9.5. And I'm looking at it right now. Strip 9.5. Okay. Oh, well, you can see this right here. Strip 9.5. And notice that we're going across, and what do we got? We've got a normal sinus rhythm. Okay. And then notice what we get. We get a PVC. What's that? Premature ventricular contraction, PVC. Okay. And notice what they've drawn above it. A couple of arrows, see? Here's a PVC, a couple of arrows. And so that encompasses the PVC, the premature ventricular contraction. Now notice what's listed above it, a compensatory pause. What does that mean? Okay, look. You're looking at a strip, okay? And all of a sudden you got a flat line. That's the pause. Now what is a compensatory pause? A compensatory pause does not stop the SA node. Okay, the SA node keeps beating. You just don't see it very well. Okay? And a compensatory pause does not reset the normal pacemaker of the heart, the SA node. Compensatory pause does not reset the timing of the heart. Okay? Now, if you were to measure off with your calipers, and you were to measure off 2 cycles of R to R, look what I'm looking at here. Okay, 2 cycles of R to R, and then you go past, okay, you take in the first QRS, okay, which is a PVC, and then it goes all the way over to the next R wave, yeah? Okay, so compensatory pauses do not reset the timing of the heart. So if you were measuring R to R, look, kind of hard to hold the book and show you, but you go right across the pause with your calipers, and the timing picks back up on time because compensatory pauses do not reset the pacemaker, the SA node. Now, what other kind of pause do you know about? Think. We may have already come up with the answer. You know about a non-compensatory pause. And a non-compensatory pause, usually from a PAC, a premature atrial contraction. Okay. But a non-compensatory pause goes up from where? From the atrium, because it's a premature atrial contraction, right? So it goes up from the atrium and it resets the timing of the SA node, okay? Whereas a compensatory pause does not do that. Now, if you have questions on that, feel free. Now, the next thing we hit in the book, I want you to take a look at 199. And when you're looking at it, I want you to see figure 7-9, kind of like halfway down. And what's it say? Bigeminal PVCs. Gemini, I'll try to go slow here, is a type of group beating. It's a type of group beating where kind of a group hangs out together. Okay? And what I mean by that is a premature beat and some normal beats group together and hang out. Okay? Now, bigeminy is one premature contraction plus a normal contraction. Bi meaning what? 2. Okay? And then figure 9-8, trigeminal PVCs, is a PVC, premature contraction, with 2 normal beats. You count everybody in the group. How many? 3? Try. Try what? Trigeminy. Okay. And then if we hit a premature junctional, PJC, okay, it's the same thing. Okay, so they're groups that hang out together. So if I said to you, what is a junctional bigeminy? You could go, well, it's a premature beat with 1 normal beat. Count everybody in the group. 2 people? Bi, 2. PAC, it's atrial trigeminy. How many people in the group? We got the premature atrial contraction and 2 regular beats. Tri, 3. Okay, there you go. So just notice it. See if there's a pattern of these guys kind of hanging out and grouping together. Okay. Now, it can't just happen once. It's got to be a pattern of this group, planning itself somewhere as you're reading the strip. All right. I want you to look at page 202. And on page 202, kind of at the bottom on the right, is something called IVR. That stands for idioventricular rhythm. Now, anytime you see ventricular rhythm, most of the time, it's going to be a wide, deep, tall QRS. Okay, what is QRS? 0.10 or less, if we measure it, right? Beginning of the Q or the beginning of the R to the end of the S, right? Or sometimes you just see that R. Idio means peculiar to that particular rhythm. Okay? It's like saying oneself. It emanates from this thing. So IVR goes from 20 to 40 beats per minute. All right? I want you to take a look at strip 916, holding it up. Page 202. Okay, now if you look at that, I'm just seeing if I was right here on the, well, it gives 41 beats per minute. Now I wouldn't say 41, just one beat is over, okay, in IVR, because IVR goes from what, 20 to 40. Notice how wide, deep, and tall those QRSs are. Okay. And look what they call it. They call it an IVR rhythm. Idio, peculiar to the ventricles. Ventricular rhythm. Now, go over to page 203. You guys watch medical shows, right? Sure you do. Okay. What's the name of that medical show, Peggy, you always watch? Yeah, right here. She likes to watch medical shows all the time. Okay. So, if you go over to page 203, strip 917, you see a word, agonal. Agonal is a Greek word. It means dying. You ever watch when somebody dies, how the monitor, they show you the monitor, right? And the amplitude of the wave, the height and depth of it vertically, gets smaller and smaller and smaller, and all of a sudden you see the flat line. Okay. So agonal rhythm is sometimes called a dying heart. You see the rate going down. Okay. I would say if you get a really slow beat, like 15, 20 beats per minute, that's agonal. Okay. Usually. You can also call agonal respiration. If you've ever been with somebody as they die, their breathing will stop and then all of a sudden go, that's agonal. It's dying respirations. Remember, normal temperature, oral, 98.6. Rectal, 99.6. Axillary, axilla under the armpit, 97.6. Normal blood pressure, 120 over 80. That's normal. Normal respiratory rate, 14 to 20 breaths per minute is normal respiration. Okay. Now, did I leave anything out on what? Vital signs? Why do you think they call it vital? Because the patient doesn't live well unless those are functioning pretty good, right? Okay, but there's also one more, and people call this a sign. A sign you can see, touch, feel, right? EKG, it's a sign. X-ray, sign. Hematoma, sign. Okay? A symptom and signs are objective, which means you could use one of your senses to quantify it's there. But then there's symptoms. Symptoms are subjective, okay? And subjective, I mean, the patient has to relate to you what's going on. Maybe they come in looking like that. You go, hi, how's it going? And they won't say anything. I'm really depressed. Well, you don't look depressed, So symptoms are subjective. Usually the patient's family or the patient has to relate some of those to you. Now, we get down to the bottom of page 203. What do we hit? An accelerated idioventricular rhythm. An accelerated IVR. The ventricles normally pace what? 20 to 40 beats per minute, right? This is accelerated. Go up from 40, go all the way to 100. That's accelerated. 40 to 100 is accelerated. You can get an accelerated junctional rhythm. What do junctions do? 40 to 60 beats per minute. If you take 60, go all the way up to 100. That's accelerated junction. Now, go a little bit further. But notice something about bottom of 203 when we're looking at it. Everything look okay to you because you're comparing everything to normal sinus rhythm, right? Anybody got some ideas of why we would call that an accelerated idioventricular rhythm besides the fact that the book says, yeah, that's what it is? We want to think a little bit. We want to use some of the skills and so forth we've got. Okay. And what I'm saying about that is it's, yeah, fast rhythm. Well, not really fast, but fast. It's 88. So that's above the 40, right? 20 to 40 is ventricles. Okay. So it's above 40. We're going all the way up to 100. The rhythm is what? Regular. What do you see? A bunch of ventricular beats. How do you know they're ventricular? They're wide, deep, and tall. When the ventricle beats, it's usually something big, wide, deep, and tall. Okay? The P waves are what? Absent. You know what? Sometimes they're hidden inside of the QRS. Sometimes they march right out the other end of the QRS. Okay? So the PR in an accelerated IVR are not measurable. Why? Because you can't see the P. All right, QRS, take a look at that. Normal measurement, right? We're measuring with our calipers. Normal measurement of QRS is 0.10 or less. What's this? Well, it's 0.14 to 0.16. Is that normal? No. What's that mean? The QRS is really big. Wide, deep, tall. Just got to keep that in mind. All right. Now we're going to go over to page 204. I'm going too fast. Get an adult beverage. Pour it. Okay. We hit on 919. What's it say? Normal sinus rhythm, figure 919, page 204, NSR. You can also call it RSR, with 3-beat run of idioventricular rhythm. Now, if I take 3 or 4 ventricular beats, what did I say a ventricular beat? Wide, deep, tall, right? I would call it, okay, let's see what this is. 300, 150, 100, 75. That's 75. Okay. So you can do that. You can say I've got 3 ventricular beats. Now here's something I want to know. Take a look at those ventricular beats. Are they one, focal, or are they multifocal? Remember, focus and area. Okay. And usually when we talk about focal, we're talking about potential pacemakers. We're talking about backups to the SA-node. Those all look the same, right? Good. Therefore, they're unifocal. But you got to be worried about. We don't like ventricular rhythms anyway. They're not good. Because if you start getting multifocal, how do you know they're multi? Multi means what? Many focal? They look different. Okay, their thumbprint isn't the same. They don't represent they're coming from all areas of the ventricles. Guess what VFib is? Multifocal PVCs, all firing at once. Take a look at figure 922 on the very next page. I'll assume that's page 205. We've got atrial fib. Now, that's a good question. How do you know that's atrial fib? Take a look at it. I mean, I've got some QRSs. I can see the QRSs. Is the rhythm regular? No. If you're going to tell me about atrial fib, here's what I want you to say. I want you to write this down. Practice it. F waves, fibrillatory waves. There's no P waves. Okay, so all this shaking between QRSs is fibrillatory waves. What's that mean? The atrium are just shaking. Take a look, if you were to take calipers and go R to R on figure 922, would they space out? And the answer is no. So F waves, fibrillatory waves, no P waves. Here's the big sentence. Irregularly irregular. Irregularly irregular. Irregularly irregular what? Ventricular rhythm. The rhythm in atrial fib, remember, marches out. Why? Because only an occasional one will get through. Now, let me stop right here and remind you about some more numbers. This kind of sounds like some test questions coming up, huh? Okay, I can go for that. Try this. How fast is fib? Well, let's do it this way. I taught you that any rate on an EKG above 100, I don't care whether it's SA or atrial or junctional or ventricular, anybody's rate above 100 is tachycardia. Simple. Any rate below 60 is bradycardia. Brady means slow, cardia is heart. So below 60, bradycardia. Above 100, tachycardia. Man, we gotta get back to this word. Paroxysmal. Paroxysmal. Paroxysmal is what? Sudden. You're saying you're taking notes and all of a sudden you feel it. What the heck's going on? Okay, I can feel it because I've got atrial fib. So in atrial fib, you get multiple ectopic atrial spikes, but no P wave in atrial fib. F wave, fibrillatory waves, and the atrium don't contract at all. What are you worried about? I mean, blood comes from what? The superior and inferior vena cava back to the right atrium. From the right atrium, when the atrium contracts, it goes through the tricuspid valve, tricuspid, down to the right ventricle. When the right ventricle contracts, it goes upward to the pulmonary artery to both lungs. Pulmonary artery looks like a T, like a T. Yeah. What are we worried about? When blood sits in the atrium, it has a tendency to clot. So we want to make sure our patient's on a blood thinner. The other thing we may want to do is make sure they have something like, this is the lock. How do drugs work? The drug is a key. What's it fit? A lock somewhere in the body. Now, if it doesn't fit the lock, it ain't going anywhere. Just goes, it's almost like, I hate to use this, but I will. Remember, this is medical. It's almost like sperm. I'm serious. I'm not trying to joke around with us. Almost like sperm. Sperm will try to impregnate any cell in your body. It will. It hit a bone cell. Hi, I want to get pregnant. No, I don't do that. Why? It doesn't fit. It's not supposed to fit. Okay. Here's the idea. A key is the drug, a lock on different organs. Okay. So with atrial fib, we may want to put them on calcium channel blocker, beta blocker, something like that. What are we blocking? Beta 1. It's a lock on the heart. It loves stimulants, coffee, caffeine, cocaine, whatever. It loves that stuff. Okay. You got to watch it. Because the more of that you take, the more irritated the atrial fib becomes. If atrial fib is below 100, it's controlled. If it's above 100, it's called uncontrolled atrial fib. Take a look at the bottom of the page. I'm assuming page 205. I just had to look to sure. They didn't label this page. What do you have? Polymorphic ventricular tachycardia. Torsades de pointes, French. Twisting of points. If I took a rhythm, or ribbon, that's good, huh? And I twisted it. It looks like a twisted party streamer. Some of the complexes are high, some of them are low. High, low. That kind of outline a twisted party streamer or ribbon. Okay? It means twisting of points. And notice it says polymorphic ventricular tachycardia. Torsades is a form of VTach. It only happens in short bursts. Short bursts, you may lose consciousness, and that may be it. Okay? Polymorphic, poly means what? Many. Morphic, shape, size. Okay? All right. So a lot of people in torsades believe there's two pacemakers. Not that they've ever proven this, but two pacemakers. One firing amplitude of high complexes, the other low. High, low. It's where it has this twisted party streamer outline. Now, let's go back to a word I just said. Suddenly, something happens. Okay? And when it happens suddenly, if it's tachycardia, it's not about 100 anymore, okay? But it's 150 to 250. Okay? If you remember that word that I gave you a couple of pages back, I'm gonna go back here for a second. I'm looking for it. Give me a second. Something happens suddenly. If it's a tachycardia suddenly because something's very irritable to a substance, to a food, to who knows what, okay, it can fire. Atrial, junctional, or ventricular ectopic foci can fire suddenly without warning and take over pacing of the heart. If it's a tachycardia, it will be between 150 to 250. If it's flutter, I'm going to mention this again in a moment, it's 250 to 350. If it's fib, and fib is hypothetical, but if it's fib, guess what? It's 350 to 450. Pretty fast. What's the problem? First of all, the chambers don't fill very well at that speed. You know, like 350 to 450 do that. So what happens to your cardiac output? Down the hill. All right. Now, another thing I want to bring up, somebody in the class brought this up. I want to thank them. PEA, pulseless electrical activity. What's that mean? Well, you're seeing a rhythm on the monitor, but the patient's dead. In other words, you're seeing electrical activity, but the muscle cells aren't responding to it. And it's called pulseless electrical activity. So if you check a pulse, karate usually, you're not getting it. Never go for an emergency, never go for radial. Why? It's too distal, it's too far away from the body. Okay. Go for carotid. It's large, it's big. You know, it's a good one to check. Now do me a favor. Go over to page 208. What are you looking at? VFib. There can be coarse VFib, really tall, and there can be fine VFib. In other words, the amplitude, the height or depth of it, real fine. Now, can you shock VFib? Yes. We may want to put some drugs aboard to give it a little bit better chance, but yeah, you can shock it. That's why we have AEDs sitting around like little lunch boxes, right? What does that stand for? Automated External Defibrillator. We're doing CPR. I was testing some suits over in Allied Health 3 a while back, and so I had, we have little mock-ups of AEDs that they can use in practice. So they're doing CPR, and somebody goes, "Here, I've got the AED." Okay. What they should do? Put on the pads. Now, can you still do compressions while you're putting on pads? Yes. Okay. When you're doing compressions, remember a couple things. Hard, deep, and fast. Hard, deep, and fast. Little interruption. Okay. Very little. Because every time you stop, what happens to the BP? It goes all the way down. Huh? And the AED will determine, it's been programmed with algorithms and everything, it determines whether it will shock or not. About every 2 minutes, it's going to reanalyze. You know what it's going to say? Analyzing heart rhythm. Do not touch the patient. Now, it's pretty simple to hook up. The first thing you always do with an AED is turn it on. I'll go Slayer. Okay. That's the on and off switch. Well, that's a tough one. Then you put the pads on. One pad goes here, downward to the left. The other pad right along the ribs here. Kind of like this on the side. Yeah. Make sure when it says do not touch the patient, that's exactly what it means. People get weird out there, holding their hand. Bobby, come back, Bobby. I know you can make. Stop that stuff, because if we shock him and you're touching him, you're going to be on your bottom thinking God just talked to you. It's not going to be pleasant. Like a mule kicking you. For every minute that we don't shock somebody with a shockable rhythm, their chances of survival decrease by 10%. I say that again. For every minute that we don't shock them, the chances of survival decrease by 10%. It's not a very good statistic, is it? Oh yeah, but we can save people by doing CPR. Sure we can. Absolutely right. And we always give the patient the benefit of the doubt. We do our thing, and hopefully they come back. But you know what? CPR in and of itself, we do anything else but CPR, about 5% or less effective. You go, you're kidding? No. I used to work ambulance. Every time we did CPR on somebody, guess what? Most of the time, they died. Now, I don't want you to get afraid of this. I just want you to hear what I'm saying. I am making. Why? Because it's less than 5% effective. So you go, well, what should I do? CPR. Keep doing it over and over again. Keep doing what you need to do in the meantime. Like what? Ventilating, checking things that you need to check, like pulses. But AED is a big thing. A big thing. Somebody else ought to notify 911. Now, the only thing I don't like, 911's been getting, I feel, a little strained sometimes, because they want you to hang on the phone and talk to them. I just hand the phone to somebody else and go, here, you talk to them. I don't have time to do, I could do chest compressions or something. Make sure you give them a good address, a street and a cross street where you're at. If you're at Victor Valley College, well, probably, like in our room, the old Allied Health building, send somebody outside. And what, do they know Allied Health? Or what, do they have a map in the car of Allied Health? No. So they don't know where you're at. If you go, yeah, we're in the Allied Health building. Well, now they got to go to what? 10 different doors and check and bang on it? No. Send somebody out and go, follow me. Okay. 911. CPR right away. Okay. AED and ACLS, Advanced Cardiac Life Support. If we don't have ACLS available, we got to get them in the hospital, by an ambulance, with EMTs. All right. Now, this is an interesting stuff. I love this. Right here. Just one beat in a straight line. Where do you go? Well, look how the book does it. One wide ventricular complex changing to ventricular standstill. I wouldn't even mention that. If I were reporting something like this, you got 1 or 2 beats on it. I would say the patient is in ventricular standstill. I wouldn't report the PVC. What's the QRS? No, that's silly. You got 1 beat and then nothing. Take a look at the top figure. Figure 927. I'm on page 210. What do you see? P waves. Do they space out? Yeah. What do you care? Who cares if they space? They're in ventricular standstill. The ventricles are not contracting. No blood's going to the lungs. No blood's coming out of the left ventricle through the aortic valve into the aorta. We don't have any pulses. Hello, ventricular standstill. Don't measure the P's out and give them some kind of rate. Doesn't mean anything. Looking for little things I want to show you here. Okay, I'd like you to go over to page 216, everybody. And on page 216, I see right in the middle, what? V-fib. How do you know? I just call it peaks and valleys. You got ups and downs, just shaking. That's all it is. Ventricular fib and atrial fib have been likened to what's called a bag of worms. What's happening? The chambers are just shaking. They're not contracting. There's no systole. What do you got down at the bottom of page 217? Ventricular standstill. Now, I'll just throw this in. Page 217 at the top. Strep. 9s, 18. You got some wide deep talk QRS. And the ST segment, you see this? And the T wave are what? They're elevated. I'm just curious. Let's see what the book does here. Okay, I'm looking at 916 at the back. That's where all your answers are. Rhythm, irregular and chaotic. Really? I'm sorry, I can't read. 918, I was going, yeah, I knew something was wrong. Rhythm, regular. What's the rate? 107 during attack, right? P waves. See them? Sinus. PR, 0.16 to 0.20. QRS, 0.12. Now the PR is usually 0.12 to 0.20. The ribbon interpretation, sinus stack with bundle branch block. The other time that a QRS can be wide is not only ventricular, but bundle branch block, or on like an aberrant conduction. You know what's happening? Abnormal conduction. Okay. So what's usually wide, deep, and tall? Ventricular. But on a bundle branch block, things can also be wide, deep, and tall. Okay. Now look at 217. What do we have? Back-to-back F waves. Flutter. So an F wave usually stands for fibrillatory wave. We've got atrial fib and ventricular fib. Those are the only two types of fib in the heart, atrial and ventricular. But this is flutter, back-to-back F waves or flutter waves. So what do you got? Back-to-back Ps, back-to-back Papa waves, P. How's it look? Like the teeth of a saw. The best thing you can do is invert the strip. If it looks sawtooth, it's flutter. What's flutter go from? 250 to 350. 250 to 350 beats per minute. What do you see the problem with? Things don't have enough time to fill. The atrium doesn't have enough time to fill. The ventricles don't probably have enough time to fill. Okay. Not at that rate. Okay. All right, I'm looking. All right. Flip over to page 230. Now remember, we always read from what? Left to right. Just like we read a newspaper, like we read our book. Left to right. We don't stick our head in the middle and go, ah, PAC. What's that tell me? I don't know. What's it tell you? What rhythm is the guy in and what's the rate? But once you tell me that, look, let me get this real quick. 150, 175. Remember? Find an R wave that peaks on a heavy black line. Don't count that line. That's where you're going to start. Go to the right, the next heavy black line, and put these numbers: 300, 150, 100, 75, 60, 50. So you can calculate rates pretty fast there. What do I think it is? 300, 150, 100, 75. I think it's around 75. Go, what if it's a little bit more? Guys, there's no such thing as perfection when you're doing the EKG. Just get close on target. You'll be all right. What do we have next? The middle strip, 958. Got P waves, right? Nothing else. If there's no QRSs, what are they in? Ventricular standstill. What are they in on 959 on page 230? That's where I'm at. VFib. Now, as the heart dies, fib is going to go from maybe up here, big peaks and valleys, to real small, real small. Then what's it going to turn into? Flatline. All right. I'm looking. What do we have on 983? Well, I'll be real honest with you. To me, it looks like a run of V-tach. I've got, 3 or 4 beats, it's a run. If it's just one beat, it's a beat. Like a premature beat, or I like the word contraction better. Premature contraction. So a PAC, premature atrial contraction, a PJC, premature junctional contraction, a PVC, premature ventricular contraction. Now you go, well, don't you use that word? What word? Sudden? What are you talking about? Paroxysmal? No. You use it, but not here. Okay. We don't use paroxysmal with the ventricles. We just say it's a run of V-tach. Okay, you get 3 or 4 beats. It's a run of V-tach. There we go. Paroxysmal ventricular tachycardia. You'd probably be right, but it's too wordy. Try to cut your words down to as little as possible and accurately identify the rhythm and rate. Okay. Now, how about if we go to 989? Just make sure I don't tell you something stupid here. So I'm going to look it up. In fact, you guys can look it up too. 989, 989, page 240. To me, it looks like an NSR, maybe. Oh, I'm sorry. Sinus tach with 2 PVC. Let's see if I'm right. I'll be right sometime. Okay. 989. Gosh, I'm trying to find it there. One second here. Wow. All right, I'm looking. Okay. Close. Okay. 989, up at the top of page 353. The answer. The rhythm is what? Regular. Irregular with what? The PVCs. That kind of breaks up the main rhythm. You got to learn one more thing. What's the underlying rhythm? Just like got PVCs, because that doesn't tell me anything. Besides a premature, what's the rest of the story here? Huh? Tell me what the rhythm is before this happened. Tell me what the rhythm is after this happened. So what am I going to say on this one? I'm going to tell you that it's sinus tach with PVCs on what? The 7th and 8th complex. Well, I might just tell the doctor sinus tach with PVCs. All right, now, here's my question for you. Take a look at it again on page 240, bottom strip. Ready? Are the PVCs unifocal or multifocal? You guys know what I mean? Uni means what? One. Meaning what? They come from one pacemaker. Why? Because they look alike. If they're multifocal, their morphology, their size, shape, and direction are going to be different. They're not going to look alike. Now, here's a good one. Look at page 241, 991. 241, 991. I'm looking. Rhythm's regular. The rate, 188. So why am I called out a paroxysmal tach or sudden tach, or they're just in tach at 188? P waves, none identified. They were in the middle strip on page 241. Right? Where did I say the P waves are going to be? Maybe hidden by the QRS, right? Once in a while you can see them. The PR interval, if you can't see P wave, you don't have a PR. Now, if it were present, 0.12 to 0.20 is normal. The QRS, what did I tell you? 0.10 or less. What's this? 0.20 seconds or greater. They're not even sure. What's a rhythm interpretation? VTAC. Now, ventricular tachycardia seems to be more pointed. What do I mean by that? Pointed. When you look at the morphology of the shape of the QRS, more pointed. Flutter looks a little rounded. Plus, in flutter, the rate goes what? Up. What's sudden tach? 150 to 250. What's flutter? 250 to 350. This isn't flutter, they're calling it tach. And what's at the top of 241? Ventricular standstill. You go, why? I see is P wave. There's no output to the lungs. There's no output to the systemic circulation. Systemo means body as a whole. There's no output. Why? You don't have any QRSs. Guess what? Somebody better start CPR. All right. Take a look at page 248. On page 248, what do you think you're looking at? The rhythm looks regular to me. I haven't looked it up yet. The P waves look back to back. What's the ratio? I think 4 to 1. 1, 2, 3, 4. Yeah, 4 to 1. If you draw an upside down V, right? Kind of like I was demonstrating bundle branch block. Every time you get a slope down, that's one way. So it looks like 4 to 1. Let's see if I'm right. 911. Let's look it up in the back. Somewhere here. Come on, page 347. Strip 911. The rhythm is regular. Sorry, I didn't read the number right, huh? 9.111. Oh, the number's out. I'm looking for 9.111. Oh, here it is. Page 354. The rhythm, regular. The rate, 232 beats per minute. Atria. How are they getting it? Back-to-back P's. Why? Because this is what? Flutter. Okay. So I'm on page 354, I'm reading it. P waves, flutter waves. Also called what? F waves. What do they look like? Teeth of a saw. How do you know? Invert the strip. It looks sawtooth, you're good. Take it to jail, you can break out. Sorry. PR, not measurable. Why? Well, if you got 4 to 1, 4 to 1, 4 to 1, how are you going to measure it? The QRS complex, within normal. Remember, 0.10 or less. Rhythm interpretation. Here we go. Atrial flutter with 4-to-1 AV conduction. Every time you got a down slope, have imagine an inverted V. That's one way. Now, the rhythm is what? Regular. But in flutter, if you go from a 2-to-1 to a 4-to-1 to a 3-to-1, and guess what the rhythm does? It's irregular. How are you going to find out? If you have time, march out all the P's, putting the calipers on the peak of one P here, peak of the next, and then without pulling your calipers in and out, if they march out, it's regular. Do the same thing with R to R. Go all the way across the strip if you have time. All right. What else can I throw in for your enjoyment? All right. I'll reach for another book here. So let me get to it. A couple of little bits and pieces that I want you to know. Now, what if I said, in a word picture, I said a premature contraction, premature atrial, with one beat. And it happens what? A group over and over again. Atrial what? Bigeminy. A form of what? Group beating. They're hanging out together. Not just once, but pretty much throughout the strip, you see a pattern. What if I get a PVC with 2 normal beats? You got to count all the beats, including the premature. Ventricular trigeminy. What if I go 3 other beats in a premature ventricular? Ventricular quadrigeminy. Okay. Paroxysmal. PAR. PAR. OXY. SMAL. Paroxysmal. All right. Now, if you're with somebody, this is my personal opinion. People have already disagreed with it. I don't care. I worked in ambulance for several years. Was I any good? Probably not. Why? Because I'm not good at directions. Like one time I got back to the shop and I got a call from the police department. The guy goes, Bill, this is the sheriff's department. Hi. Why are they calling? Bill, what's the shortest distance between 2 points? And I paused and he goes, does that confuse you? He goes, I thought it was. Why did you go the opposite direction of the hospital? Sorry. Didn't remember where it was. Okay. Look. See bundle branch block right here? What's the first thing you hit? R. What's the next one? R prime. What's R? The bundle branch that's not blocked. What's R prime? The bundle branch that is blocked. Hello. Now, I'm just going to mention it. I want you guys to kind of maybe read about it a little bit. And next time, we'll talk about it. Axis. A-X-I-S. Axis. Axis is the direction that depolarization is moving. If you look at the muscle cells, the myocardium of the heart, yeah, they're in one of 3 states. One of 3. I can't. One of 3. The first one is polarized. When a cell is polarized, it's negative on the interior. It's positive on the surface. Negative on the interior, positive on the surface. What's it doing? Nothing. It's resting. It's ready to receive a stimulus from above. What if the cell depolarizes? The positive charges go to the interior of the cell, and the negative charges come out. And the cell what? Contracts. Okay. What if it repolarizes? It goes from contraction back to resting, polarized. 3 states of the myocytes. What are the myocytes? The muscle cells. What do they do? Contract. Hopefully. So axis is the direction the depolarization is moving. I'm trying to get in the anatomical position here, but look, how's it moving? Downward and to the left. Let me say it again. Downward and to the left. Now, before I get caught up with my last 5 minutes here, I started to say something to you. I forgot about it, so let me head back there. A right bundle branch block and a left bundle branch block. Left bundle branch block, L, B, B, B. Right bundle branch block, R, B, B, B. You go, well, how do I know? I mean, I see R and R prime. How do I know if it's on the right or left? Very simple. V1 and V2, two of the chest leads, right, is on the right side of the heart. You go, well, yeah, but I put V1, fourth intercostal space, right sternal border. Kind of look at myself trying to do this. Okay. And I put V2, left intercostal space, right sternal border. V1 and V2 are more on the right of the heart. So if R and R prime, either one of them or both, happen in V1 and V2, like Victor, that's a right bundle branch block. If they happen in V5 and V6, guess what? It's a left bundle branch block. Kind of makes sense? So what is axis? The direction that depolarization is moving, the positive charges. How are they moving? Downward and to the left. Hopefully it makes sense. If not, you can call me. Now, the other thing I want to mention is the direction we said is downward and to the left. It's like a little arrow, like your finger pointing. The arrow pointing, like your finger or a line or something pointing, is called vector. V-E-C-T-O-R. If I say, what's the vector? You go, the vector of depolarization, downward to the left. They went that way, downward to the left. There's a way to figure out vector. There's a way to figure out degrees vector. And I'll help you do that maybe a little bit later. Guys, hope you have a nice evening. Okay. A real nice evening. Hope you have a great rest of your week. And thank you very much for listening.